Hey everyone, welcome back to the channel. In today's video we're continuing our series on vasoactive medications. Today we're going to take a closer look at dopamine, another key vasopressor that you'll encounter in critical care. We're going to talk about how dopamine works, its clinical uses, dosing, potential side effects. So let's go ahead and jump right in. So dopamine is a naturally occurring catecholamine, and it's also a neurotransmitter, but in critical care it's used as a medication to support blood pressure and improve organ perfusion. It's a unique drug because it has dose-dependent effects on the cardiovascular system, making it useful in a variety of clinical situations, from shock to heart failure. So let's break down how dopamine works. Its effects are dose dependent, meaning that the impact on the body changes with the dose. I'd like to just preface this portion of the lesson by stating that there have been mixed results when dopamine has been studied, focusing on low doses or renal doses of dopamine. From what I've gathered, overall, the renal protective effects and low dose dopamine or renal doses have been largely discredited. While it can increase renal perfusion and urine output, it doesn't appear to improve long-term kidney outcomes, and its routine use for this purpose has been pretty much abandoned. But with that being said, at low doses, from 1 to 3 micrograms per kilogram per minute, dopamine stimulates dopaminergic receptors in the kidneys, which leads to vasodilation and increased renal blood flow. At medium doses, anywhere from 4 to 10 micrograms per kilogram per minute, dopamine stimulates beta-1 adrenergic receptors, which increases heart rate and contractility, which helps improve cardiac output. And then at high doses, above 10 micrograms per kilogram per minute, dopamine primarily activates alpha-1 adrenergic receptors, which causes vasoconstriction, also increasing systemic vascular resistance and therefore blood pressure. So this dose-dependent effect makes dopamine a very versatile tool in critical care settings. So dopamine is used in a few specific situations, such as shock, especially when hypotension is due to low cardiac output or bradycardia. It can improve heart function at moderate doses. It's used in heart failure, in cases where additional inotropic support is needed to boost cardiac output. And then, as previously mentioned, in renal failure, low-dose dopamine was once used to improve renal perfusion, but this is no longer a recommended practice. Evidence showed it didn't really improve outcomes. Nowadays, dopamine is often used when there's a need for both inotropic support and vasopressor activity. So the dosing of dopamine is based on weight and the desired effect. So as previously mentioned, low doses, 1 to 3 micrograms per kilogram per minute, is primarily dopaminergic, which affects renal blood flow. Moderate doses, beta-1 effects dominate, increasing heart rate and contractility. And then high doses, over 10 micrograms per kilogram per minute, it's primarily alpha-1, which causes extreme vasoconstriction to raise blood pressure. So because of dopamine's varying effects, it's important to titrate it carefully based on the patient's clinical status and goals of therapy. Also, continuous blood pressure and cardiac output monitoring are essential when administering dopamine, just to kind of assess the patient's reaction. As with any vasopressor we've talked about, dopamine has potential side effects to watch for. Tachycardia and arrhythmias are a huge one, due to its beta-1 stimulation, especially at higher doses. Vasoconstriction. At high doses, dopamine can cause excessive vasoconstriction potentially reducing perfusion to extremities and other organs. And ischemia. Overconstriction of blood vessels can lead to tissue damage and ischemia in cases of prolonged use. Given these risks, it's important to monitor the patient closely, particularly for signs of excessive vasoconstriction or any kind of abnormal heart rhythm. So let's look at a quick clinical scenario. Got a patient that's 70 years old, 70-year-old female with acute decompensated heart failure and low cardiac output. We put her on dopamine. We started at 5 micrograms per kilogram per minute, which increases her cardiac output by enhancing her heart's contractility. Her blood pressure improves due to this, and her cardiac output is increased after the dopamine administration. This case just kind of highlights dopamine's utility in managing heart failure and shock when there's a need to increase cardiac output. So how does dopamine compare to other vasopressors like norepinephrine or epinephrine? Dopamine offers dose-dependent effects ranging from renal vasodilation to strong vasoconstriction at high doses. Norepinephrine works on alpha-1 receptors, which cause vasoconstriction and raise blood pressure, and epinephrine has strong effects on both beta and alpha receptors, making it more versatile in emergencies. Dopamine's varied effects give it a really unique role in managing patients with both low cardiac output and hypotension, but it's not always the first-line choice just due to the risk of tachycardia and arrhythmias. So just to kind of sum things up, dopamine is a vasopressor with dose-dependent effects, from renal vasodilation at low doses to strong vasoconstriction at high doses. It's used for heart failure and shock, particularly when both inotropic support and vasopressor activity are required. You need to monitor closely for tachycardia and arrhythmias and be cautious of excessive vasoconstriction at high doses. Understanding when to use dopamine and how to titrate it properly is crucial for managing our critically ill patients. So I hope you guys learned something from this. The next video I'm going to talk about phenylephrine, which is one of my favorite vasopressors that we use in the ICU. Thanks.